Okay. So good morning, everyone. Yeah, you're welcome to this orientation meeting. It's important to have this as we begin our rotation in Mwanamjimu because the children we take care of are quite different from the other children. They are not just a smaller version of the other well-nourished children. A lot of changes have happened in their bodies, which if we don't know and we treat them like the others, we can cause dangers to them. Actually, people who are very senior in this field know that health workers contribute a lot to the death of these children because of not knowing those differences, and that's why we are here. Yeah, so first of all, there is high mortality amongst children who have some, yeah, especially in the inpatient care, leave alone the outpatients. And most of the studies show over 20% mortality. And over the years, despite the changes in protocols to reduce mortality, the mortality has remained high. And though the protocols say if we follow them, especially from WHO, acceptable mortality is below 5%. Though we have SPIA standards, which says for a resource limited setting, acceptable would be below 10%. So we need to strive to be below 10% mortality. But there's been a lot of change here in Mwanamjini. When I was in an intern, SHO's mortality was like 30% in this unit. We were always competing with special care unit who has the highest mortality, but it was so high. But thankfully, a lot has changed. Mortality has come down, and especially with increased knowledge, a lot of research being done in the field, expertise being developed, and it's really multi. There are many things that have happened to make the mortality come down, including having doctors in the night, because mortality was happening a lot at night. And the current protocols that we are using significantly reduced our mortality, especially controlling use of fluids, IV fluids. That one has been known. So that's why you as interns need to know that fluids actually kill these children. So let's bear that in mind. So we target to go below 10% in our mortality in the ward. So even if you're already on the ward, I'll not assume that you all know the definition. So according to WHO 2013, if a child has weight for height Z score below -3 or more below 11.5 centimeters for a child who is 6 months to 5 years, or bilateral pedal edema. It could be generalized edema, but I'm sure you know edema can come from many sources. So it should be a child with edema which looks nutrition. It's not very difficult to kill. If a child has edema, that brown sparse, silky hair, and then skin changes and apathy, then most probably it's nutrition. If they have generalized edema and they are playing around, they are happy, don't think about malnutrition. So if they have those features, then they have some. So we have edematous and non-edematous. In the new guidelines which are coming out, we are trying to change from the term severe acute malnutrition because some of it is not acute, as you've already seen, you know. So especially the non-edematous one, it would have developed over a long time. So we are now going to use severe wasting or moderate wasting for the non-edematous and then nutritional edema. I think that is a more acceptable term. So though the edematous is usually acute, the non-edematous may not be acute. So management of some, okay, we can manage, okay, what is there? Yes, management of SAM happens in the clinic or in the community. The largest number are managed outside the hospital by the, okay, in outpatients. 80% of children in SAM are managed in outpatient. Now, that 20% we see are the most sick one who have medical complications or they have generalized edema, or they have both edema, even if it's grade 1 and wasting. We have a criteria for admission, which is in that little book, which you need to look at when you're admitting. We should suit the inpatient criteria. But once they have a medical complication, they need to be admitted. So that criteria, I will not go into it. So when we talk about inpatient management of SAM, the first word is it is phased treatment. It's in phases. So that's why we are studying the physiology. Why should we then treat them in phases? So the first stage is stabilization. The children, when they come, they are so sick. There's a lot of changes that have happened in their body. They're undergoing reductive adaptation, which we are going to talk about. So the aim of this phase is to help them stabilize metabolically. You get it? So we have to handle them very carefully in this stage. So when they finish this phase, we are saying two phases, and yet you see like there are three. There are two phases. After stabilizing them once they are stable, and we know they are stable if the medical complications have cleared, that's number one. Number two, if they had edema grade 3, it's now grade 1 or less or no edema. Then number three, they've improved appetite. They're expressing appetite. They want the mother's food. They are not getting satisfied with the F75. They have improved their appetite. So those are the signs we use that now we have stabilized them. They are well enough. They're interested in their environment. So once we finish that phase, then the next one is rehabilitation. So in rehabilitation, that's where we are looking for weight. That's where we are really treating the malnutrition. Here we are trying to get them out of danger. So that's why stabilization is very important. We give them the F75, manage their medical complications, and then we also do other testing for TB, HIV. Their malnutrition may just be coming from TB. Yeah? It may not be a poor diet. It may be TB giving them severe malnutrition. Then, so we say we have two phases with a transition in between. That's why we don't call it transition phase. It's because we are trying to raise the calories gradually. You don't want to all of a sudden move from F75 to like full dose of calories. It has to be stepwise in order to avoid refeeding syndromes. So those are the phases of treatment. Now we are going to go through the physiological changes. And when you look at severe malnutrition, it's like there are two different syndromes. The ones for wasting and then edema. Before you were taught, I don't know whether in primary, secondary, I don't remember whether in secondary, we talked about marasmus or gouache, but I know in primary we did. And they were saying, what is the cause of marasmus? Lack of carbohydrates. And the cause of kwashiorkor? Lack of, was that primary or secondary? Primary. So we have to unlearn. That was wrong, very wrong. It's not that lacking carbohydrates gives you wasting and lacking protein gives you edema. What have you seen when you're clocking? Is it a different diet for these ones and for these ones? No, the diet is not different. So for each of them, they lack protein and calorie. It's protein and energy malnutrition. But lots of micronutrients missing in that diet, which are very vital. Many micronutrients. So which the course that they take doesn't depend on the diet they were on. It is more of the body's response to the starvation or the body's response to the poor diet gives you whichever syndrome. So if the child adapts well to the starvation, they will end up with non-edematous malnutrition. Because if there are no resources in terms of food, the body will look for them in other places, in the fats, then you start losing fat. If fats are finished, they look in the proteins, that is the muscle, and then the child will slowly waste away. So they are adapting well. Hmm? But now, so that's how they end up. Now, if they end up here, there is that maladaptation too, in the starvation. So the body, instead of doing what this body is doing, and there are changes even in their hormones. There are many changes. First of all, these ones tend to be older children. This one is usually faster. A child goes to the grandmother, and in 1 month or in 2 weeks, they come with edema. It's very short. When the mother either has a baby or gets pregnant and wants to stop breastfeeding, send the baby to grandmother, and in 2 weeks, they have edema. It's acute. It's usually triggered with a quick change in diet, so there is no time to adapt, or an illness. Those are the common things with this one. But before, the biggest thing for us, when I was an sexual intern, you get a child with quash or some edema, the first question you ask, has the child been with the grandmother? 90% chance it is a yes. So grandmother, that's why we call it Jaja disease, because they would be with the grandmother, and the same phenomena where it was described in Ghana. Actually, the word kwashiorkor comes from Ghana, and it was described in 1922. Cecil Williams and the others did a lot of work, and they got that diagnosis, and they were able to connect the diet to what you were seeing, the edema. But there is always that deprivation. It has always been here. But now, these days, when I see, also when I class, we see children who are with the mother getting some edema. That are the epidemiological changes in disease. Things used to be in a certain way in the past, and a lot has changed. But it is about the body's response. I'll not go into the details on how edema evolved, because up to now, more than 100 years since it was described in some edema, it is still an enigma. It's not clear what causes edema, because animal studies, when animals are starved, they don't get edema. But human beings who are older and shorter duration have been found to develop edema. It's a mix of, it's now what is acceptable. It's a number of reasons why we get edema. One of them being the low albumin, because the low albumin alone does not explain getting this. Because even these ones have low albumin, by the way. It can even be lower. So low albumin alone does not explain edema. But there are hormonal changes. Cortisol. Who of these do you think has more cortisol? This one, or wasting, or the wasting have more cortisol, the stress hormone. So they are able to overcome the stress and to respond appropriately. So they have less cortisol. And there are also other hormonal changes in these children. But other theories, actually the explanations are of theories with pros and cons. So the other theory is oxidative stress. It is thought that the lack of antioxidants in the body leads to oxidative stress and damage to tissues, which makes them leaky, and then edema develops. There's some evidence too, but there's also some evidence against. For example, children who are at risk of getting kwashiorkor or some edema, when they are given antioxidants, micronutrients, it does not prevent them from getting it. So then they say, I don't think it's the only explanation. It may have a role, but it's not the one. So there are many things responsible. Hormonal, including sodium retention is more here. And then immunity also. You need a good immunity to develop some edema. their CD4s are higher than these ones. So it is thought that maybe you need a certain level of immunity to develop this. Then the social workers think there is a lot of psychological reasons behind getting some edema. You see how they have apathy, how they've been deprived, a number of them removed from the mother. It's psychologically traumatizing to the children, and it leads to some hormonal changes, then your stress, and then they get edema. So today we are not talking about the physiology of edema, but the physiological changes in acute malnutrition. So this reductive adaptation happens. So the body's response to starvation is to go in survival mode, if I use that term, because they have low calories and the body wants to survive. So the resources are given only for vital organs so that life can go on. So the little resources are given to the brain to keep working, and maybe the heart, but mainly the brain. So everything else goes down. Do you know crying takes calories? So the child will not cry. Even when you put in cannulas, what have been your experience? When they are new, you prick and there's no calories for crying. There are no calories for moving around. So physical activity goes down. Some mothers who don't know me, they say, my child is so peaceful, but that's dangerous. Yeah? They shouldn't be failing to cry. But because they are trying to conserve calories, so there are changes in every part of the body because of no calories. And we are going to go into the details. So the whole body in reductive adaptation, physical activity goes down. What have you observed? How active are they at admission? Yeah, they are not. So we have changes in the cardiac functions, renal function, intestinal functions, liver function, muscles, at a cellular level, sodium, potassium, pump, protein synthesis, and some others, the immunity and temperature regulation. I saw we were talking about a child who was hypothermic. Was it you on that group? Hypothermia is common. So maybe to start with this physical activity, there are some devices we can put on children to measure how active they are. And we have them because Dr. Esther did a study on physical activity of children with severe acute malnutrition. But another study also done found that at admission, activity index was so low compared to discharge. This is a discharge, but still lower than the normal healthy controls. And when it came to Dr. Esther Nabukeera's study, she was looking at the level and predictors of physical activity at discharge, and then found that the level of physical activity at discharge was low, and the factors, if they had a weight for height Z scores and more on that, the higher they are more and weight for height, then the better their physical activity. That's how I say. So the smaller ones had less activity. Then the duration, if they overstayed in stabilization, then they had less activity, physical activity. So they generally are inactive. That's why it's easy to tell between a child with edema from malnutrition and a child with nephrotic syndrome. You've seen them running around with their anasaka and happy and playing. You'll not see that. If you see that in a child at admission, please take them out. They don't have some. If they have generalized edema and they're happy and playing, that's not some. They will be apathetic, dull, inactive until they keep improving with the nutritional rehabilitation. So at a cellular level, because ATP is needed for the sodium potassium pump to work. When you have limited calories, it's in effect, it's not working well. So sodium potassium activity is reduced, and cell membranes are more permeable than normal. So this leads to increase in intracellular sodium and decrease in intracellular potassium goes with magnesium. So that's what's happening. So that's why these children retain sodium and they are low on potassium. And that's why their fluids that we use have less sodium and more potassium. That's the explanation. This at a cellular level, but also at the renal. So that's why you don't give the standard WHOORS. We use Resomal. Resomal has half the sodium and it has potassium in it. When we are giving even fluids for shock, the fluid we give we use half strength Darrows, half the strength of sodium, because normal saline has 0.9%, but we give them 0.45% sodium. That's what we are trying to create even as we mix the fluids. When we use Ringers, Ringers has potassium in it, but we could even add, if you just give normal saline, you're not giving, or high strength saline, you're not giving them potassium, yet they need potassium. You get it? Eh? So this is for us to understand what's going on and why we manage them that way we do. So when we go to the renal function, glomerular filtration is reduced. What happens when glomerular filtration is reduced? What happens? Little urine outputs, meaning you're retaining the fluids. Okay, so the capacity to excrete excess acid or water is reduced, sodium excretion is reduced, so sodium again, apart from the cellular level, at the kidney level, we are retaining sodium. And UTIs are common. Okay, there's an SHO who just recently did this study, and I've forgotten the figures, but we have quite a number of UTIs in these children, and we don't routinely look for it. Though good enough, the first-line antibiotics tend to cover for it. Now, this one, if you forget anything I say, this is the most important thing for us to know. The changes at the cardiac level. Because now we have been, they are responsible for a lot of changes in the way we manage these children compared to the well-nourished children. Their blood pressure is low. That is from studies. Remember, we are not routinely checking their blood pressure. But renal perfusion and circulatory time are also reduced. Plasma volume is normal, and red cells are reduced. So the cardiac output and stroke volume are reduced. So any increases in the blood pressure can easily acutely give them a cardiac failure. So maybe I'll add this. There are changes. There are studies where they've looked at echoes on children with severe malnutrition or ECGs, but mainly what they find is that there is reduced ventricular dimensions. That is like the end diastolic diameter, end systolic diameter, posterior. Generally, the wasting you see everywhere does not spare the smooth muscles. Even the heart muscle is wasted. So they have low muscle mass, cardiac muscle mass, and even the function there. So the left ventricular mass is significantly reduced from a number of studies actually. Left ventricular ejection fraction is reduced. They have some other changes you can look up, but good enough they improve. They mostly affect them in the first week when they are with us. That is during stabilization. So that time is really critical. After that, when they are in rehabilitation, they are much better. But when we have them initially, we have to be careful with the fluids. So from experience of people who have worked on nutrition units for a long time, and even from published research, Dr. Bacho et al., she did her PhD, she was working here on this unit, and that's the first time, and even WHO kept putting it up Fluids kill children with severe acute malnutrition. IV fluids, blood kill these children a lot. So somehow when I came to this unit, we are following WHO guidelines, but there are some things we are not emphasizing. So we would give them, I don't know whether any of the SHOs were ever here or a new different unit where we are alternating Resomal with F75. Okay, we did that not so long ago. So when we would find a dehydrated child, we would give them the fluids in the first 2 hours, and then after that, continue with fluids, alternating 1 hour F75, the other hour Resomal. We kept doing that. And we would forget to stop, and then you come on the second day, the mother has been giving, and that's when our mortality was high. Once we became so strict on not giving beyond the target weight, we saw a clear marked reduction in mortality on the ward. Actually, when we looked at our data later, we found that diarrhea is not a predictor of mortality, but I think it's the way we were treating the diarrhea. We were giving them Resomal, and they were giving too much. Actually, when they get periorbital edema and you're rehydrating, you're giving too much fluid, and then it causes mortality. So, intern doctors, if you forget anything I've said, be careful with giving them fluids. There's a nutrition unit where they found a new nurse came. They had that bucket, it was a bucket of Resomal in the middle of the ward. So the new nurse said, it's not smart, doesn't look nice being in the middle of the nutrition ward. Let me put it aside. She put it away so that mothers didn't have access to it. That single action reduced their mortality by a half. You get it? Yeah. Fluids, even orally, Resomal, water, what? Let's be very strict with the fluids. We give them fluids when we must. That's why we do not have plan A, ORS. Don't give them when they have diarrhea and they are not dehydrated. We only give ORS when we know we have some evidence of dehydration. You see, the other children, if they have diarrhea and they don't have dehydration, we give them plan A to prevent dehydration. For children with malnutrition, we don't give them fluids to prevent dehydration. You get it? I was saying it on the group, and we're saying, yeah, I put on ORS plan A, give ORS Paluz too. We don't do that. You get it? So we don't do that. We have to be very serious how we diagnose the dehydration. And when we diagnose the dehydration, then we rehydrate appropriately. So it's mainly the changes in the heart that make us be strict with fluids, because we give them fluids and then we overwhelm a flabby heart, which is wasted and dysfunctional, and you're giving extra fluid. As for blood, some nutrition units say whether they give blood dyes. I'm here to look at our data because that thing sparked a question in my mind. I have failed to get someone to do a retrospective check on our, but I don't think so. Here I've seen them surviving. But maybe it also depends on the timing of your blood transfusion. If you give them in this first 1 week and you don't have a clear, you can actually just fill them with your blood transfusion. That's why you transfuse at a lower HB. And carefully, slower, under Lasix routine. Whether you give blood, we know what's going on in this heart. Actually, they'll survive anemia, but they'll not survive your transfusion. Because first of all, the anemia is chronic. So they compensate. The compensatory mechanism come in place. I've seen them with an HB2 and they are not even in heart failure. So if you can, HB is 3.9, I have to transfuse, your transfusion may kill them. And their HB 3.9, you say, okay, 3.9, let's check it tomorrow. Oh, it's 4. Let's check the other day, 4.2. You've escaped. You save that child better than giving them a transfusion. So we need to discuss when we want to take such decision. Yeah, if it looks stable, HB is 3.9, even if the guidelines say we transfuse below 4, we take a case by case because that transfusion you give may be the killer. You get it? So we are careful with them. When we are giving them fluids, it's better to cross-check with someone. Should I give fluids? The eyes look sunken, but this the fluid loss is not significant. We should be discussing those things because you may give fluids and cause more harm. And yet you may withhold when they need them. Because sometimes when I tell people this talk, they fear the fluids too much. Even the hands in shock, they appear to give fluids. So it's a delicate balance that if they are in shock, they really need. If they are dehydrated, they tend to survive dehydration. But make sure they don't get into shock. Make sure you don't fluids kill these children. Okay, there are also changes in their intestine because the production of gastric acid is reduced, intestinal motility is reduced. They tend to have big abdomen, protuberant, and motility is reduced. Their pancreas is atrophied, so they lack enzymes, digestive enzymes, amylases, in the gut, they lack the amylase, they lack the lactase enzymes because the small intestines are atrophied and the enzymes are made in the villi at the edges. So once it's atrophied, you lack the enzyme. And from research done here, 25% of them have lactose intolerance. Remember, aphids have a lot of lactose, both the plant peanut, because it's milk-based, that RUTF, and the milk, both F75, F100. But somehow we still give them the feeds. Their lactose intolerance is transient. As they recover, it goes away. So we still give them, even if it is this high, and we observe. If the diarrhea is not dehydrating, we keep with the feeds. But if it's dehydrating and they get in shock, that's when we change. We give lactose-free. That's when we give the lactose-free milk. So the absorption of nutrients is also reduced. So we have the study, the ProBSAM study, and we looked at the gut functions of children with SAM, and we found they have reduced enterocyte mass. So the wasting is also in the intestine. Don't think that their skin and bone and the intestines are intact and their heart is intact. The wasting happens everywhere, okay? Including the gut, then intestinal inflammation, then there's increased bacterial translocation. That is, those gut organisms easily enter into the systemic circulation. So it is also a source of infection. So gut microbiota, we also looked at their gut microbiota changes. And it's one of the explanations for some, by the way, some edema especially. Their gut, when you look at their stool, those normal flora are so different from healthy children. And as they improve, it tends to they have less diversity, they have more pathogenic organisms. So as they improve, then it becomes closer to the normal healthy controls when you do studies on these children. Then they have other changes. Their skin, subcutaneous fat, atrophied. So when you see their skin, we don't do skin pinch when looking for dehydration. There's a time we stop the abdominal skin pinch and we are doing the forehead. We stop that as well because it also doesn't measure dehydration in these children. So don't do a skin pinch to look for dehydration. Has any of you done it? If you do, it may be so slow because of the wasting. It may be 10, 20 seconds. And they are not dehydrated at all. They don't have diarrhea. They are taking 2 hourly feeds. They are not dehydrated, no losses. So skin pinch does not mean dehydration. No. So we don't use it. It's not one of them. So many of the signs, including eyes, sunken eyes. Many of the children with severe wasting have sunken eyes, even adults severely wasted. We've seen them. So what is causing the sunken eyes? Loss of the orbital fast. So don't use just sunken eyes as a sign of dehydration. because it may not be. So we also found that most of the glands are atrophied, sweat glands. They rarely sweat. Anyone seen them in P1 stabilization sweating? They don't sweat. You observe. They don't sweat. The sweat glands are atrophied. How about tears? Many of them don't cry, even tear glands. So it's not a sign of dehydration in some. It is a sign of dehydration. Other children, if another child who is well nourished cries without tears and they have diarrhea, that's a sign of dehydration. Here, the tears may not come because the tear glands are atrophied, not because they are dehydrated. You get it? Though we see some who cry with tears, it's not universal. Some their tear glands are not so affected, they still have tears. But if you see one without tears, don't be quick to say it is dehydration. It could be atrophy. And then for my PhD study, I did thymus gland scans for 400 children. And their thymus gland is so atrophied. Much, and then even at discharge, even 8 weeks after discharge, it has not reached the healthy control. So there's atrophy, including salivary glands. Their liver, this is another one for us to note as we are practicing. Yeah, protein synthesis will reduce abdominal metabolites of amino acids are produced. Their capacity to take up and metabolize and excrete toxins is severely reduced. So some studies have found increased toxicity to paracetamol. That's why we don't give paracetamol on our ward. So those who are just coming, no paracetamol for these children. The problems of paracetamol far outweigh paracetamol toxicity, far outweigh the problems that fever would cause. So we do tepid sponging and we focus on the cause of fever. We manage the cause of fever. If someone is so worried, use other things. But even if you say you're going to use maybe ibuprofen, make sure they are fed. You don't give them a gastritis or what. But usually, there are few children who we really want to be. Once we take it sponge, treat the cold, avoid the fever phobia, because people want fever. If it is not 38.5 and above, actually all guidelines, we do not do anything about fevers in children. Why do we, is there a benefit of that high raised temperature when there's an infection? It is the body's way of killing off some organisms. It resets the temperature thermostat so that the temperature rises and some organisms are killed. But health workers who don't know that, temperature 37.5 or history of fever and normal temperature, we are giving them paracetamol. Yet all the guidelines will say, give paracetamol if the temperature is 38.5 and above. Isn't that the guideline? Is that what we are doing? Eh? Yeah. So even other children, paracetamol is given for high temperature. Low grade are beneficial. So that's why it's in the guidelines. Maybe you see it and you ignore. Why are they telling us to give paracetamol for 38.5 and above for all children, whichever guidelines you look for? Because the low grade fever has a benefit. Then when it is 38.5 is when that's when you need to bring it down. Okay, so we don't give paracetamol. That's for emphasis. But on the group we're discussing about pain, usually when they have pain, we give morphine. That pain usually should be severe. I don't know what was causing pain in that child. The wounds, yes. Yeah, then we give you titrate them often accordingly to say safer for them. Then the immunity is affected a lot, both the innate and the acquired immunity. For example, yeah, maybe this is a bit too detailed, but maybe we can share both. Yeah, so impaired function of the epithelial barriers, that is the skin and gut, we already talked about that. Reduced neutrophil microbicidal activities, fewer dendritic cells, complement is affected, then low antibody titers after certain vaccinations, delayed type hypersensitivity reactions, and reduce expression of some cytokines, and then lymphatic tissue, especially thymus and bone. So under nutrition, yeah, affects the infection. Okay, leads to the infection because of their lower immunity. So undernutrition affects the immunity, and then they get infections, and they get undernutrition, and the cycle goes on. But also infection leads to impaired absorption, and this impaired absorption also leads to worsening undernutrition, then infection. So those cycles, they go through those cycles. Okay, temperature control, they behave like neonates. You put them in a hot area, they heat up. You put them in a cold area, they become cold. So the ward actually needs to be warm in the cold, especially when it's cold. Before we used to have baby cots, but because of this, we changed to big beds so that mothers can sleep with their babies to make them warm. So is this child severely malnourished? I don't know whether the picture is clear. They're sweating. They are sweating. Yeah. No, he was, but now he's recovering. So when they recover, they can start sweating. Yeah, so it's difficult for them to sweat. There are other changes that are interesting in these children, this is just interesting. Who gets catatonia? Have you ever seen anyone with catatonia? I just want to put this to show you that these children are more complicated than we think, and we are yet to discover a number of things with them. Who gets catatonia? Psychiatric patients. Also, the children with some get catatonia. If you're keen, you'll find it. We have even some videos that we took, especially when we were doing some research. Now, these children, some of them, the ones who get catatonia in the study that we saw, the numbers were low. So we couldn't really make very meaningful analysis. But they tended to be the very sick ones, and they tended to be the ones with edema, not non-edema. So you put up the hand of this child, and like the hand is forgotten. The hand can stay there for the rest of the day, or then the feet, and then they remain up. So if you look for it, you may find catatonia. They have nice long doll-like eyelashes. Who has seen them? Yes, that exactly. You've seen. They are like, they don't have to pay for them. So, but though studies have been done still, and they've looked at eyelash zinc compared to hair zinc. People have done research on all these things, and they found this zinc. They found heavy metal deposition in their eyelashes. The heavy metals, they are lead, mercury, those heavy metals. So then they have longer limbs. It's to do with hormones, shorter body, longer limbs. That has been observed, especially in the hands with wasting. Those are observations. We've seen some with gynecomastia. We've observed children who sleep with eyes half open. You've seen those ones. When you see one, actually think about hypoglycemia. Though I was told about that by someone who had been a professor on a nutrition unit for 17 years, told us that that when they sleep with eye open, think about hypoglycemia, and then when we came, whoever I would get, we would check the sugar immediately. But I got back to him and said, whenever we check the sugar is actually low. He said that maybe in the past or what, and yet I wish we could study that as well, because it's an observation you commonly see. So when you see that, at least check a blood sugar. Those are observations. The child is sleeping, but eyes are. So in summary, the changes are everywhere in the body. These children in the brain, they have lethargy, they have apathy, they have irritability. This picture is from an article from on SAM. Someone wrote a review on severe acute malnutrition and the physiological changes. And I like this picture because it says so many things. So they have long-term effects on their cognition. Which ones do you think are affected more, the edema, the non-edematous? Long-term, like maybe they will not get to medical school like you because they suffered an episode of severe non-edematous. Edematous has more, it develops more acutely, but it has more long-term problems. So the edematous types, they have, you remember it's the one where there's maladaptation. The others adapt well, they tend to navigate, their bodies try to go around the starvation. These ones fail to adapt, it's a maladaptation. So they have more long-term problems. It's a worse form of malnutrition, actually, the edematous one. It's a worse form. If you're to, someone is to have one type, if they are to choose, they should choose the non-edematous one. So they decrease appetite. There are changes, including thyroid functions, impaired cortisol and growth hormones. Respiratory tract infections are so common. Impaired cardiac function, the liver, we talked about it, immune functions, and then the gut changes, the immunity, the renal function, the skin. So the whole body is affected by malnutrition. Don't just look at this child as a smaller form of a well-nourished child. There's so many changes. Some have not even been well understood up to today. The parents have told you some observations that we've made. So it's not just protein and energy, but their micronutrients are also low. Anemia is the order of the day. The normal HB is 8. That's the average HB. You see one with HB 10, you're surprised, or 11, or 12, you're impressed. So they have so many micronutrient deficiencies. So when you look at them, look for them. Sometimes you see those with a hypertrophied gum. That's vitamin C. And it's so important in healing, immunity, So let's think about those things. Vitamin D deficiency is so common. You will clinical manifestations, but we try to confirm it. We try to get some evidence, even if we are proxy measures, so that we treat. If they are vitamin D deficiency and we don't treat, their respiratory tract infections will take long to improve. Then their immunity is also low, so we have to diagnose and treat vitamin D deficiency. Zinc, it's the order of the day. By the way, their diarrhea, we don't give them zinc. Do you know why? Who wants to know?
The feeds have
Very good. Yeah. The feeds have enough zinc. The zinc we would be giving, like we give ORS and zinc for the other children, we give Resona. If they are on therapeutic feeds, don't add zinc. Actually, studies show too much zinc has been associated with increased toxicity. We calculated the zinc in the feeds that they'll get in a day and compared with giving them a tablet of zinc. And we saw that it's the same. If you give more, you give too much. And we don't want toxicity. So when we take them off therapeutic feeds, like some of them, we give them lactose-free milk because maybe they are diarrhea, they are getting dehydrated. And so those ones, please don't forget, give them zinc. If you give them lactose-free milk, you give them zinc because that lactose-free milk doesn't have zinc. Yeah. So this is a picture of a child whom we had on this ward. She was one of those long-stay children who stayed for a long time. She had HIV, TB, chronic diarrhea. But I went to see the child later, and the child has, you can't even recognize. So it is a fight, but we end up with smiles of the mother and the baby after years, after a while. So the only other thing I want to go through with us, because I've been talking about, we have this I think we need more of them. It's the stool scale. The reason it is around because we were over diagnosing the area. This is published, because part of that study. If another points that they are when they change they have the area, show them the scale, and then say, how does the area look like? If they stay here, then you know it is normal. But if you didn't, the mother would say, hey, no child is there. And it is this kind of stool. You know, it's because when they come here, we give them a liquid only diet, so the stool changes. So the mothers seeing the changes too, they say now we have developed diarrhea, but when it's not diarrhea. And if you take it to be diarrhea, you may and yet it is normal still. If it is here, it is diarrhea, it is this stool, it is 3 or 24 hours. It will qualify for diarrhea, but we are not worried about it. From our studies here, we saw these ones don't get dehydrated. These ones there, these are not diarrhea. So if they point here, you become alert. This is potential for here you say because they are using some water, a lot of water, minimum water loss in the stool. So this stool helps us, first of all, who is at risk of dehydration. So that we monitor and think about it. And when we validated it, because if another place here, then we check with the health, look at the stool and also point. So we saw that there is the actual actually another points there, it is actually there. Make the point here. Some of them is none of those is like water. Tap water, it can't be on the sheet right here. So those ones are actually the ones for this of dehydration. So the ones you can give water that if this one root. If they are saying that they have some edema and there is number one on the stool scale, it's number one or even worse, like water, it's like urine. Those are that you can consider giving reasonable after. Consider, by the way, it is considered. You may or may not, if it's so frequent, that's when you really want to give. But if it's maybe times you say it's not, but it's not so many times. We don't even call it plan A, because if you call it plan A, you're giving the area. They are risk too. We don't even say that we be screen. But what I it has to be water for you to consider the reservoir in a child who's in the because these ones are the case information. So this is how we travel their sample, this dehydration. When the eyes are sunken, it will not be dehydrated. So this is the last thing I want us to talk about. We have this on our body. So you know, if you are with diarrhea, please know enter doctor. Reference accurate and the best. It's not like if you ask, if you check, you don't know enough. Those are the real good ones. You're making sure you're giving your patient the best. So please look at this. It's very clear. How do you determine someone is in shock? They have lethargy, unconscious, and has cold hands. plus any of those, either slow and fulfill time, weak or rapid fast. And then if they have dehydration, then that's dehydration for sure. And then you give them fluids for sure. And even I want to go so much into that. Make sure it's 1 hour. The biggest cause of it failing is giving it in 2 hours or 3 hours. You can't get the volume and give it in longer. It doesn't correct the show. Make sure it runs in 1 hour. That's my observation. If you give it, if people say it has not worked, you go and check. So when you start running, put 10 a.m. We make sure by 11 it's all in. But if someone can put up at 10, then it's at midday, it's still running. It will not correct. So that time, it has to be put in within that time. And the right fluids, we give 1-to-1, ringers, and dextrose. So watch out for hypoglycemia also. If they are not feeding, if there is potential, then you may need to give the dextrose along, but not here. And then if they have dehydration and they have dehydration, but they are not in shock, then this is how, first of all, deciding that they are dehydration. The starting point is history. A history of significant recent fluid loss. They have diarrhea, they have vomiting, or they are not feeding. Then they are prone to getting dehydrated. Don't just check any random child. They are on the ward, then you do sunken eyes, low skin pinch, dehydration, give fluids, you may cause a mortality. So there has to be a reason for dehydration. So the first thing, why would the child even be dehydrated? They have to have diarrhea or vomiting, or they are not feeding. Then there is a reason for it. Then when you have it, then you start looking for the sign. Look for the signs which have come up during this period of loss. Remember, they can say, so don't leave the men. Just ask, how are the eyes? And some of them tell, since yesterday that when they started, the eyes lost your waiting. That is now something is within the. So not just something else, it has to be associated with the loss. Then that's when we become the sign. Then we look at the veins. If the veins are collapsing, they are probably dehydrated. And then in addition, look for the most objective measure. Give them a drink that is water or reasonable. Don't give them milk. Milk doesn't taste fast. Give them, if you see them fighting for the cup, they finish and they throw away the cup very angrily. They are crying out for the cup. Those are signs of thirst. The body needs water. It's one of the most, please don't ask the mother. I've seen people asking, is the child thirsty? Observe it yourself. Get some little reservoir, give them or watch the mother give it and see how eagerly the child is drinking. Then they just sit and stop. That if they are eagerly drink, that alone tells this child is eagerly and starting hydration the way we do it. So this child actually has to when some waters. The ones with edema don't really show signs of dehydration because they have a lot of water in their body. It's just in their own space. We only give if they tell you this child is passing like water and many times, then that one is the one we give. It's also somewhere in blue on the chart, even the ones we put it there in blue for the one with edema. If the area is too much water, then we give after. We don't give them this one because we don't actually see the sign. Because the water is there. If we give this, we give much water. Their functions are actually more affected than ones with some edema. So you don't have to load them with fluids. All you know is too much water in the area. Then you send it to access that needs to replace because you know. And when they are in shock and with some edema, most times it is septic shock unless they have a lot of diarrhea. So when we are monitoring And once we start rehydration, we start by taking the weight at that time. Unless you cannot, then you can use the last weight. And then we calculate the target weight, which we should never exceed. So they use the 10% of their weight in the middle. So you calculate the target weight. So if the child is 5 kilos, what is the target weight? Can you calculate? Yes. The target weight. Yeah. So the easy way is to get the 10% and add them. Okay. 5 kilos, 500 grams is 10%. So 250 grams, that's 5%. So you just know 5.25. So we should not go beyond 5. So that is it. So even as you're multiplying, so you start giving some of these things we learn in the world. It's good whenever we get the challenges for different people want us to participate and then we go through. So after 2 hours, we monitor weight after 2 hours, and what you get at that point gives you what goes on next. So if there is weight increase after 2 hours, and the child is clinically improved, continue until you may continue. And then, but do not exceed the target. If the weight increases less, but the child is not there. For example, you know, 4.33, and the child is once probably once from other things not there. Because if dehydration is a problem, correct, they should clinically look at that. Then there, you want to stop the dehydration and go for whatever other problem. If there is no weight change, it means the losses are exceeding the fluid you're giving. They are losing too much. So there we are now increasing to 10 mils per kilo per hour. Because there is no weight change. You start at 5 kilos, after 2 hours, you're still 5 kilos. That means we've done nothing with our fluids. So now we give a higher to overcome the losses. Now, sometimes you start at 5, and at 2 hours, you're now on 4.9. What does that mean? You're losing too much. So here we increase now at 20. We have to overcome the too much losses. So that's the reason behind all this. That's why if we actually follow these things, our mortality really came down. Our children die a lot. And other studies done that side, diarrhea is a predictor of mortality, that is really its management. If we make sure we do this the right way. I want to stop here because I know it's a bit too much. So anemia, we talked about when we give anemia. Some and HIV, we start ARVs as soon as they are stable. We don't wait so long, maybe not on the day of admission. We stabilize them a bit because of the because of the metabolic complications. Fever, we don't see. That is our end of hope.
Could you say something about the repeating syndrome?
Oh yes, repeating syndrome. Because of the changes in the body, because of reductive adaptation, the body has gone into that state of survival. Because there's low circulating glucose, so insulin is very low in the body. Insulin is low. So when you start feeding, insulin raises. And what happens when insulin goes up?
Pressure goes down. Pressure goes down. If insulin goes very high, you also get hypoglycemic. Yes, there are some of the things that happen. Phosphates also go down.
So that's what happens. So The reason we actually starting a low-calorie diet is to avoid fitness. You're giving less calories so that the insulin inside is not so high. It is just that. So when we give a lot of calories, then insulin goes up, then we get those shifts of electrolytes, and that is the insulin. The phosphates are very low. Phosphates are low, nitrogen is low, magnesium is low because of that insulin it has risen. And it's a dangerous clinically we can see them. We can get one clinical edema, we can get heart failure, we have clinical features, respiratory rate. They clinically look worse most children. Here in the world, we don't get it in stabilization because the feeds have the inlet the phosphates before they use the phosphates are adequate and the calories are low. Now the feeding we get on this is during transition because now we are increasing the calories. So when you increase the calories, the history goes up. So if you rush to send a child from P1 to P2, and if your time says, this child has stayed 2 weeks in P1, you go to P2. Even if again is grade 2, or if you go, those are not to get refeeding. The children do just this. So if they are going slowly, we wait out to avoid refeeding because refeeding is life-threatening. So they can get refeeding syndrome and die. Sometimes the children is anyone who is undergoing starvation, like someone does a fast food, taking heavy, they will break and take too much. The insulin goes very high, and because those shifts are life-threatening, someone can actually die from that. So even our children can die from refeeding syndrome. So let's not be in a rush. If a child has requested in P1, let us have a discussion. And we don't want the algorithm to go up so fast. What happens if the algorithm goes up so fast? Yes, the edema is booked and so fast. And then the fluid goes quickly into the intravascular space. Then the heart is pumping, increased volume, and the heart is weak and flabby, dysfunction. You can cause more problem. So they give us the pills, we go slow. We have people who are going to private hospital, and they find they have access to all of this. Obviously, this will be some handle. But I find that I don't have here decided to give item. That is not to do. You brought a child with sound, you get angry. Look at Isaac, he's smiling. So if you give IV albumin, you may kill that child. Actually, they called me one time in a private hospital. Yeah, that child who couldn't come here to Manam Jinusa, I went there, and I found when they were running IV albumin, stopped it immediately, but I think I was too late. The child died like in the next maybe 5 hours or so. The heart failure and failed to come out. So it has to be a slow process because the child has undergone a lot of changes which need to reverse slowly. That's why those electrolyte abnormalities that they come with, you give the F75, it is absorbed slowly, then slowly the potassium reverses without you giving. Now the calories which come in the body, the sodium potassium pumps wakes up, starts working, and then it corrects. Things start correcting. That's what happens in P1. As we give the milk with all the micronutrients, the appropriate amounts of calories, appropriate amounts of proteins, not too much, things start reversing slowly from that reductive adaptation. That's what we are doing in P1. We are not looking for weight. We are looking for the body getting back to stable, get out of that state of inactivity, trying to survive. Now we introduce them slowly. It's all calculated properly for what they need. And then when the body has now stabilized, then we go for calories, but we step up slowly so that we avoid refeeding syndrome. But if you find go back to P1 to start is we have the foods we fail them. So 35 and they get to feed it, we give them feeds. But we can just give some injections to avoid the person using. That is one of the solutions. The other one that happens to under 6 months mostly, because they have another I know how to say rehabilitation.
My second question, you have sufficient vitamin D, or would it be helpful to supplement for some of us children?
So then they did the kids as the recommended daily other habits only. So when we have deficiency